Hello, and thank you for joining today's event on medical review findings and wound care reviews. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education Department, and I'm going to be your facilitator for today's event. And I'm also joined by other members of Provider Outreach and Education who will be assisting with the chat as well as the Q&A for today's event. A few housekeeping items before we get started. As I mentioned briefly, on our website, WPSGHA.com, we have a training center link at the top of the page. In our training center, you're going to find all things education, such as the training materials like our slide deck, any upcoming educational events, access to our encore presentations that you can actually watch outside of YouTube. Those encore presentations are generally on our encore page for about 60 to 90 days, but they're always available on our YouTube page until that information is either changed or updated. If you have questions during today's event, just place those questions in the chat and send them to all panelists. Finally, if you have any feedback about your experience today, there's going to be opportunities during this event to take our survey. Jennifer's going to place a survey link in the chat now, as well as at the end of today's presentation. So if you find you need to disconnect early, you have access to the survey link now. If you are listening to this event as an encore, we encourage you to take the encore survey as well. The encore survey link should be in the top left of the screen. It'll be a little white eye, and it's also available at the end of the presentation, but there's also a link in the description as well. In every event we do, we have to provide you our disclaimer. And our disclaimer basically says we prepared this as a tool to assist our provider community, but know that Medicare laws, rules, and regulations often change. It's your responsibility as a provider to make sure you are following the most current laws, rules, and regulations that are in place on the date of service that you are providing them. We're going to provide questions and our answers to any questions based on the laws, rules, and regulations as they stand today. But know that CMS, their website is where you should always go to make sure you have the most current laws, rules, and regulations and that you're following those. All right, acronyms. Medicare's full of acronyms. If you've never joined a Medicare webinar before, you know it's like acronym soup. So these are acronyms that I may refer to in our presentation today. These acronyms will appear on various slides throughout the presentation. If I happen to use something that you don't know, just place that in the chat and Jennifer will help get that answered for you. My objective for today and the agenda, my objective is to help you, our providers, in lowering denial rates that may become an error because medical review. And we want to focus mainly on the wound care in the outpatient setting. And I want to point out that this presentation does not address metabolically active human skin equivalents, substitute dressings, burns, skin cancer, HBO, or even billing of wound care. I have had a lot of questions that came in, not a lot, but a handful of questions that were pre-submitted that came in on wound care billing. And know that I have already spoke with an associate of mine that we are planning on teaming up maybe towards this, the end of the spring, early summer, and providing you a webinar that focuses just on billing. Today's event is on the coverage criteria, the medical review findings, and how to avoid those findings. Also know that on March 13th at 1:00 p.m., We will be covering skin substitutes and the coverage criteria of the updated LCD all by itself. This LCD is set for projected implementation of April 13th. So this gives you, our provider community, ample opportunity to understand the coverage components, what has changed with the skin substitutes, and make any plans in your practice. This will help lessen any potential impact that learning about these new changes, how they may impact you. So please plan to join that event. I'm going to have Jennifer put a link to the live events page back into the chat one more time for anyone that may have joined after she first placed it in there. And you can use that link to register for the skin substitute event. All right, so to help you lower denial rates upon review, the agenda for today and how we're going to accomplish this is by reviewing the coverage criteria for wound debridement. We're going to discuss the documentation requirements, and then we are going to highlight some common review findings and how to avoid them. Moving on with coverage. We have an LCD. Our LCD L37228. This LCD covers guidelines for wound care involving debridement, electrical stimulation, and electromagnetic therapy, as well as negative pressure wound therapy, low frequency, non-contact, non-thermal ultrasound or mist therapy, and topical oxygen therapy. Our medical review team refers to this LCD for the coverage criteria and documentation guidelines to make review determinations. I'm mostly going to be focusing on debridement and related documentation today. If we have time at the end of this event, I will take you out and show you how to find this specific LCD, depending on how much time we have at the end of this event. Debridement is defined as the removal of foreign material and or devitalized or contaminated tissue from the adjacent to a traumatic or infected wound until surrounding healthy tissue is exposed. So that's how it's defined in our LCD. This LCD applies to debridement of localized areas such as wounds and ulcers. The mere removal of secretions or cleaning of a wound does not represent a debridement service. At least one of the conditions that's listed here on this slide must be present. So pressure injury, stages 2, 3, or 4, venous insufficiency, arterial insufficiency, wounds with exposed hardware or bone, etc., even diabetic foot ulcers. Should deep tissue pressure injury or stage 2 injury progress into an unstageable or stage 3 or stage 4 requiring debridement, then documentation supporting this must be included in your medical record. On our slide are some wound care standards, and we're going to talk about these quite a bit as we move on through the presentation, because there is some required or standard wound care that we need to see present in your documentation that has happened before and sometimes during and after debridement services. So things like optimal nutritional status, making sure that your patients are achieving optimal nutritional status. Are there concerns about the patient's nutrition? Are you encouraging high protein diets? Are they supposed to be following a specific caloric intake or specific macronutrient guidelines that you want them to follow. As well as things like maintaining a clean, moist wound with appropriate moist dressings, good glucose control. If you have diabetic patients, what are you doing to help them achieve optimal glucose controls and keeping their glucose within a certain range? And is there things like infection prevention that you can help the patient with as well? So these are things, again, we would expect to see in your documentation that you are doing that are standard wound care treatments that need to be sometimes before, during, and, after debridement services. So as we move on, let's talk about debridement itself. Again, debridement is defined as that removal of foreign material or devitalized or contaminated tissue from or adjacent to a traumatic or infected wound until that healthy tissue is exposed. The goal of debridement is to remove that devitalized tissue and decrease the risk of overall infection. It's also done to promote wound healing and prevent further complications for your patient. There's different methods that providers can choose to use. So your documentation, you should document the type of debridement that's being performed. We want to know how much tissue is removed, from where, and what method what method was used to do that. In the next several slides, we're going to talk about more specific components of debridement and documentation. But before we move on to different components, let's talk about debridement, including selective and non-selective debridement. Selective debridement refers to the removal of specific targeted areas of devitalized or necrotic tissue from a wound along the margins of viable tissue. Occasionally, bleeding and pain may occur with this as well. The routine application of topical or local anesthetic does not elevate active wound care management to a surgical debridement. Selective debridement includes selective removal of necrotic tissue by sharp dissection, and that includes things like scissors and scalpels and forceps, and selective removal of necrotic tissue by high-pressure water jets. Selective debridement should only be done under the specific order of a physician. Wound care non-selective debridement includes things like surgical debridement, and that's the excision or wide resection of all necrotic or devitalized tissue, possibly including excision of viable wound margins. This is usually carried out in an operating room by a surgeon. Anesthesia is usually required, and it's frequently used for deep tissue infection, drainage of abscesses, or involved tendon sheaths, or even debridement of bone. Now, sharp debridement is the removal of necrotic or foreign material just above the level of viable tissue and is performed in an office setting or even at the patient's bedside with or without the use of a local anesthesia. Sharp debridement is less aggressive than surgical debridement, but has the advantage of rapidly improving and healing the conditions, in that ulcer, in that wound. These typically are services of recurrent nature, usually superficial or repeated wound care. Enzymatic debridement is debridement with topical enzymes that are used when necrotic substances to be removed from a wound are things like a protein, fiber, and collagen. The manufacturer's product inserts contain indications, contraindications, precautions, dosage, and administration guidelines. And our expectation is that you follow those product inserts with the manufacturer guidelines. And finally, under the non-selective, wet to moist dressings. And this type of dressing is usually kept, is to keep the wound moist. This is a type of dressing that's used to remove drainage and necrotic tissue from the wounds. And that again falls under your non-selective. As we move on, sorry for that, got a little barky dog there. All right. As we move on to documentation. First step in documentation is the documentation of a covered condition. So things that we're going to look for in your documentation, not just that the ICD-10 is contained within your billing, but the actual condition is listed in your documentation. Just as we presented at the start of this webinar under the wound care basics, the first thing we're going to look at upon review is at least one of the conditions listed is documented. Next is a certified plan of care. Where is the wound at now? What issues did the patient have prior to the wound development? What kind of history is there? Like what other treatments were tried? How often is the wound care going to be done? So the amount, frequency, and duration. What are the goals of wound care services? We need accurate descriptions of the wound or wounds. Is there full, partial thickness, subcutaneous? Is there muscle or bone involvement, etc.? If the services are going to be provided by a therapist, then the physician also needs to certify that overall plan of care. All right. Evidence of your plan effectiveness includes measurable changes, such as decrease in draining, decrease in inflammation. We want to know about any swelling, any pain, dimensions, and how the tissue looks. Is it necrotic tissue? Is there any spot to the tissue, etc.? So that again helps with the ongoing evidence of effectiveness of your plan to make sure those types of things are documented. And then as well, we're going to expect like physician orders, physician follow-up. We're going to look for diminished areas of ulceration, any kind of resolution of the surrounding tissue, including any erythema or wound exudates, decreased symptomology, etc. So I spoke about briefly on the physician follow-up. We also need evidence of physician order for the services. So the physician progress notes, if the services are being performed by the physician, will suffice with that. But if they're being performed by someone else, like a therapist, then we need to see evidence of the physician order and the physician's progress notes. When we talk about pictures of the wound, try to have pictures that are as clear as possible to support the wound. Generally, when pictures are scanned into an overall EMR, we can get a decent picture when you submit those through our provider portal. However, sometimes we still get records via hard copy, and we get a photocopy of a wound. And we can't really see very well in the photocopy, of the documented picture of the wound. We suggest, you may need to mess with the photocopy a bit to lighten it as much as possible So, you know, the borders, et cetera, the sizing can be seen. Also, additionally, treatment records for your patient. So treatment records include wound measurements and then comparisons from your start of care. Debridement evidence, so the tissue removal, the method utilized, the characteristic of the wound before and after debridement. Is it bigger after debridement? What do our borders look like? What do our edges look like? Severity of destruction. Is there undermining or tunneling? Is there any necrosis, infection, evidence of reduced circulation? And then appropriate modifications of the treatment plan as necessary. And that includes any complicating factors to healing. And what measures that you took to control those complicating factors. So this seems like a lot of information, and we're going to continue on with a little bit more documentation just to kind of wrap things up. Any medical conditions that may inhibit the healing. And this could include some of those standard wound care things that we talked about before, like things like nutritional status. Is this person not having optimal nutritional status, which is impeding their healing? Is there any predisposed conditions like diabetes or congestive heart failure, et cetera, that may lead to a delay in the wound healing? So if those things exist, make sure they are captured in your documentation. If they're diabetic, again, are we getting optimal glucose control? Are we checking periodic A1Cs to see what that, if they are in fact getting optimal glucose control, et cetera. And then finally, if you issue an advanced beneficiary notice of non-coverage, if that's applicable to your care, we would need to see that as well. And so that would need to be included in your documentation requirements or documentation. And these requirements can also be found in our local coverage determination. So as I back up a couple of slides, we went through a lot. I want to go to the certified plan of care and just reemphasize, regardless of in what stage that we are looking at wound care services, we always need that initial evaluation and plan of care, because we need to see where you started and what your goals are. And if things aren't healing adequately or aren't progressing, what you're doing to modify this plan of care and get the patient moved on. Or are they a patient whose wound is not going to heal, so your wound care is not going to make a difference? As we move on, let's talk about some expectations of your documentation and expectations of improvement. So the goal of wound debridement is to remove that devitalized tissue, decrease the risk of infection, promote wound healing and further complications. So there's an expectation of improvement that must be shown in order for Medicare to cover these services. Medicare expects that with appropriate care and no extenuating medical or surgical complications or setbacks, that wound volume, surface dimension, those things should decrease over time, or the wound would optimally start demonstrating, granulation tissue. Wounds that fail to demonstrate measurable reduction in size at 2 to 4 weeks, despite appropriate therapy, are really unlikely to heal. There's also literature to support that a reduction of less than 40% for venous or less than 50% from diabetic ulcers at 4 weeks is an overall predictor of outcome for healing. So evidence of improvement means measurable changes or sometimes decreases in some of the following, these things listed here on your screen: drainage, the color, the amount, the consistency, inflammation, swelling, the pain the patient's having, wound dimensions, so the diameter, the depth, the length, is there any tunneling going on, and then necrotic tissue or slough of that wound. Again, we expect the wound care treatment plan to be modified in the event that there's not appropriate healing being achieved. Debridement should be performed by a healthcare professional acting within their scope of his or her legal authority. Thinking of supporting measurable signs of healing, let's always document in objective and measurable terms. So as we get to measurable signs of healing, let's think of those objective and measurable things that we can document. Measurements include overall wound size and depth. Avoid subjective terminology. Saying words like the wound is smaller really doesn't give enough evidence of healing. However, measurements that show a 3 millimeter wide wound is now a 2 millimeter wide wound, that sure does. That gives us a lot to go by. We also look for decreasing amount of exudates from wounds and amounts of drainage in the type and the viscosity or the exudate. Everyone in your office or in your place of service should use consistent measurements and terms and use consistent scales to report amounts. Perhaps everyone measures the amount for drainage by measuring what is on the bandage, including, length and width on the bandage. Number of bandage changes needed in a day, etc., also helps with that. Also, what types of drainage are you seeing? Is it serous drainage? Is it sanguineous drainage, serosanguineous? Is it purulent or even foul purulent? And then also the viscosity. Is it thick? Is it sticky? Is it thin? Is it watery? So again, I encourage whenever you can, always document in objective and measurable terms. When you're questioning your patient about their pain when they present and the patient says, I'm feeling better, go back and get that quantitative information to align with what they said subjectively. So you said your pain was a 5 out of 10 at your last wound care visit, and today you report a 3 out of 10. That gives us a lot of information. So keep those two words in your back pocket, objective and measurable. Now we're going to move into review findings and errors. So incomplete or insufficient is insufficient information is a most common error. Basically, we're not getting all or some of the documentation to support the service as medically necessary. The most common things that are missing that are not documented are the type of debridement. Remember, you have to tell us what type of debridement you're doing. Also, things like measurements, your plan of care, or even specific components of the plan of care, and the documentation of one of the required conditions. And those we noted at the start of the presentation. Moving on, we have no debridement evidence. Things like the documentation did not show that there was any tissue removal to support debridement was actually done, or again, the type of debridement like sharp or enzymatic, etc. If it's sharp, what type of instrumentation was used? Also, we don't get evidence that the debridement was down to the subcutaneous tissue level. Additionally, lacking description of the wounds before and after debridement. So that is a necessary component that we don't always get. And then finally, the signature and credentials of who performed the debridement service. So those are one things that is, we get lack of documentation to support that evidence as well. Remember, Medicare only pays when the allowable people, physician, non-physician practitioner, or therapist that are acting within the scope of their practice and licensure perform the wound care debridement. Measurements. I've touched base on measurements a lot in the documentation. So it should be no question that it's also a review finding. Without pre and post measurements, we cannot assume that debridement was done, that was done was reasonable and necessary, and that it's actually helping make improvements to the wound. Not only do we have instances when we have no measurements, your measurements need to be documented and marked as such. We need to have the length, the width, the depth. Often wound borders are larger after debridement, so we need to see that before and after. We can't assume that the larger measurements were pre-debridement. Depth must be included in your measurement. Every progress report should contain measurements and should contain your pre and post. And that's the place that we're going to look for the most progress to be made when we're reviewing documentation is through the progress notes. So your measurements can be done every treatment day, but must be included with every progress note. All right, there are a lot of findings that go with plan of care, and that's because there are a lot of components to documentation to the plan of care. First of all, if you're treating a patient, you need to have a plan. Where they are, where you want to get them to, how you plan to get them there, what do you plan to do, over how long. So over how long is your amount and frequency? And then what are the goals? So complete a plan and submit that plan if we request documentation for review. Additional things often missing from the plan include detailed descriptions of the wound. Again, what type of wound, what size, what's coming out of it, what do the borders look like, etc. Additionally, you have to document the potential to heal. So we usually see this in the evaluation and overall plan of care as well. So as I said before, treatment goals are most important and most importantly noted when there's a plan in place, and we find those generally in the plan. And if you're not showing or your patient's not showing signs and symptoms of healing, then what are you doing to modify that plan? Because in the case that you're providing services with an expectation to improve that patient's wound, if no improvement's being shown, then what's your next step? What do? Do you give up? Does this patient need a potential surgical intervention? Is there a potential amputation, etc.? Goals. Be sure to document SMART goals in your plan of care. Sometimes the reviewers are not seeing goals that are specific, measurable, attainable, relevant, and time-bound. So specific must be specific to the patient and their wound type. You cannot have canned goals for every patient with the same type of wound. They need to be made specific to your patient. Measurable, what do you expect to see and what amount of time? You need to document your expected improvement, and if you're not getting what you expect, how are you readdressing that goal to make it more specific to that patient, to make it more measurable for that specific patient. Achievable. This goes hand in hand with measurable. Is it achievable for this patient with this type of wound? If it's not, how are you changing your plan? Does wound care in this manner need to maybe be discontinued due to it not being achievable? Is there no healing happening? These are all things that you should think about when you're setting your SMART goals. Relevant, again, relevant to your patient's wound care needs. Your goals should align with your higher objectives. Making sense of the big picture for your patient-specific wound or wounds. So the goal direction addresses the specific needs of the wound and the patient's overall health. And this should align with the primary objective of promoting proper wound closure and preventing complications, which in turn makes the goal meaningful and impactful for that patient-specific situation. And then finally, time-bound or time-based, however you want to refer to that. What is the time frame in which you anticipate the expected healing? Your goals, even short-term goals, should have a component of time-based associated with them. What do you want to see by the next section, by the next month, by the next time that you're doing debridement, by the time the wound is healed, etc. Remember, the LCD does contain information in the documentation of SMART goals, so it is something that we very much review for. Next up, complicating factors and methods to control. So this is often lacking in the documentation, the complicating factors and methods to control that for your optimal wound healing. And this goes back to things like optimal nutritional status, any medical conditions that may inhibit the wound from healing, like a diabetes or congestive heart failure, perhaps unsafe living conditions, or lack of resources to keep a wound clean and dry or clean and moist. Often these are things that are not addressed in the documentation and are very much important to ensure everything possible is being done to keep that wound progressing to optimal healing. And then finally, required conditions of coverage. That's the last thing that's missing that makes wound debridement claims not considered for coverage, is that no documentation of a covered condition for the service. So we've referred to this several times. Again, they can be found in our local coverage determination. This must be reflected in the plan of care as well. So the diagnosis code build must be included on the plan of care for the reason to perform the service. If at any time during the course of treatment you get things like laboratory results or imaging tests that change the diagnosis of your wound, you must document that, and you must you have to have a covered diagnosis to continue Medicare covered service. So if confirmatory test shows a different diagnosis, you need to go back and make sure it still qualifies for debridement services under Medicare conditions of coverage. So go back to the LCD. This slide also, if you downloaded the slide deck, contains a link straight to our LCD. And then finally, these are just some resources that will help you in finding additional education on wound care services. Now, just to kind of recap, we went through a lot today, and I know we're getting close on time, but today you actually learned about how to lower denial rates upon review, and we achieved that goal today by going over that coverage criteria, discussing the documentation requirements, and really highlighting those common review findings so you can avoid those in your own place of service. Now, before I go into some of the questions that are in the chat, I do want to go over a few questions that were pre-submitted. And the first one is, can non-physician practitioners perform wound care in a hospital setting? And the answer to that is yes, they can perform wound care in a hospital setting under Medicare as long as they are acting within their scope of practice and their state licensure, and they're properly credentialed within the facility. So this includes services like debridement, dressing changes, et cetera, depending on the specific situation and if, again, you have any state or local regulations that apply. The next one was, can physicians use a term like partial thickness when describing wounds? And yes, partial thickness can be used to describe wounds that affect the epidermis and the dermis. So partial thickness wounds are more commonly known as superficial injuries. Again, they affect the epidermis and the dermis, but not the subcutaneous tissue. What is WPS's stance on proper documenting the term ulcer and wound interchangeably in a progress note? So WPS does not have a preferred stance or preferred terminology. However, as we discussed earlier in the presentation, your documentation in your practice setting should be consistent, and especially consistent in the use of terminology. So if the use of the two terms could lead a reviewer to believe that you were speaking about two different affected areas, you should use caution in how you are documenting in your place of service. And then next was, what parts of the medical record are most important during an audit of a wound care chart? And that's all components. We went through all those documentation requirements. Anything that you have that supports the medical necessity for what you are doing should be documented. But mainly, again, back to that initial evaluation and plan of care, progress and treatment notes, your measurements, signs of healing, anything inhibiting healing, et cetera. So refer back to those documentation requirements that we discussed. And again, we had some questions come in on various aspects of wound care billing. Since this event was created to cover the clinical aspects and the review findings, I'm gonna look into co-hosting an event with another one of our outreach specialists that focuses on the billing. So look for that coming in the future. And we may be able to actually include some skin substitute billing into that as well. I'm gonna just look real quick because I know we are right at time at some of the questions that have come in. One of them is, during targeted probe and educate audits, can you request a different reviewer? If you are having issues with your reviewer and your point of contact, I do encourage you to speak with the point of contact for your facility, the senior nurse reviewer, and have a discussion with that person if you are having issues with your reviews, your chart reviews. Okay, if a patient declines or wishes to delay amputation or surgical intervention and continued intermittent debridement are necessary to prevent further infection and complications, would this be considered medically necessary? So the medical necessity component of that one, Heidi, yes, is going to depend on how you document that. And if you are supporting that, you are preventing complications, preventing infection, it would probably be allowable for, you know, a generally reasonable amount of time. So this shouldn't just go on and on forever and ever, but if you are delaying for a month, 6 weeks, then, you know, something like that, we would expect that that is documented to support that you're doing it because of the infection risk. When a picture is taken of the wound, is it okay from the physical exam portion of the note to say, refer to attached image, or is it more documentation needed on the physical exam? So it is okay to refer to an image, but is that image, you know, it depends on what that image is outlining. So if it's just a picture, we are going to expect that physician or non-physician or therapist description of that wound as well. So the measurements of it, etc. So there needs to be some sort of evidence, you know, in the documentation of that wound as well. We can't visually see how deep a wound is, or sometimes not even tunneling, just from a picture. Okay, and then in some instances, the size of the wound is increased due to the debridement. Granulation tissue may be present. However, the size of the tissue may be present. The size of the wound may not always reflect non-healing. How does the author analyze size in relation to those indications? And that one we kind of answered, Heidi, as well. We know that sometimes after debridement of a wound is actually bigger. So that's why it's important to make sure your documentation contains all of the information about what your wound looks like before and after. The sizes, the measurements, what type of debridement was used, what type of tissue was removed, etc. If we're seeing decreased depth, but maybe an increased width because of the debridement services, then that may be part of the case as well. All right, and then I am seeing a few that are specific to billing. So again, those will be answered in our billing event. And so I know we are over time, and I thank you for hanging out with me. And I've just got a few closing slides that I am going to go over. After we close out of this webinar, those of you who logged into the webinar will receive an email. You're not going to receive an email if you only called in via phone. So this email is your proof of attendance, and it has your contact hours in it if you need that for continuing education. So don't just delete it without reading it. It is kind of important, especially if you want those contact hours. If you have follow-up questions after this event, or any questions I didn't get to and you want to send those to me, email those to me at this email address that Jennifer put in, or Jennifer and I both put into the chat earlier, wps.ghA.education@wpsic.com. Make sure you put in the subject line wound care reviews and send that over. You have 7 days from today to get that information to us. If it is something that's claim specific and it requires your billing to be looked up, we cannot answer those questions. Those need to go to customer service. So please don't send us any PHI or PII over an email. I would hate to, you know, either of us get in trouble on either end for sending that type of information. Please take those questions to customer service. And finally, as I stated at the start of this presentation, we really do value your opinion. We want to hear from you on how we did on this event. So the survey for this event only takes a few minutes to complete, and we want to give you the opportunity to take it now. So Jennifer put a link to it in the chat, but also when we close out the presentation, your screen is going to look like this with the yellow triangle. It's going to come up. It's just saying WebEx is redirecting you to a survey, and we do want your good, bad, and ugly from this event. And this survey also is your opportunity to tell us what additional information you want education on in the future. So that's why, another reason why we're going to do a whole separate thing, look into doing a whole separate thing on wound care billing. All right. Thank you for hanging out with me for a few extra minutes. On behalf of Jennifer and myself, as well as all of Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.